So Leslie, you know, the biomarker, there's a lot of conversations about this HRD biomarker. I think we should try to keep it simple. I realize that the biomarker is not perfect. At least tell us what the biomarker was, both in Prima and Paula.
So the biomarker is called HRD. I call it a phenotypic assay of DNA repair deficiency, homologous recombination deficiency. So it has a score. It's 3 components. See if I can remember them. It's loss of heterozygosity, telomere allelic imbalance, and a large-scale state transition. So 3 components, and then they give you a score of which somatic BRCA is a part of the score. And so the scoring is complicated, and if you're interested, I would have you look at the package insert for the Myriad MyRisk test, but the cutoff generally set at 42.
Yep, MyRisk is germline, MyChoice is somatic. Yep.
Sorry, MyChoice, I misspoke. Thank you for correcting me. The cutoff set for Prima Paula at 42. You don't have to set the cutoff at 42. That's not really been very, stringently validated. It's just a cut point that we've chosen to use. So there are things that are not measured in the MyChoice test that contribute to HRD. And we don't know the exact cutoff yet. So it's not yet a perfect test, but if you look at the totality of all of this frontline data, it's pretty discriminatory with regards to outcome. And so although we say it's not a perfect biomarker, it's not an imperfect biomarker by any means. It can be very helpful in the upfront setting.
And because it's a companion diagnostic for PALA-1, as Matt said, it is reimbursed by CMS and others. There is a second sort of commercially available option. Again, you said it very nice, a functional test. Looking at the mutations is not acceptable. But the other sort of functional test is Foundation Medicine LOH test. Is that as good, Michael Beer? I know you've spent a lot of your career on this biomarker, or should we stick with the companion diagnostic because we don't want to mess up the reimbursement or interfere with the reimbursement? How do you integrate the Myriad MyChoice with the Foundation LOH score?
I think you just hit on it. I think it's more of a reimbursement insurance issue. If you look at fundamentally how the assays were developed, they're both based on LOH.
Right.
Myriad just added those 2 other elements that Leslie talked about. I'm not so sure how much they add, but I tend to agree. The assay works. It's not perfect. Hopefully we'll, with more research, we'll get it better and more accurate. But I remind all of my colleagues, even estrogen receptor expression doesn't predict for tamoxifen response in breast cancer all the time. So no biomarker is perfect.
So Matt, and I'm very, we're all friends. I'm going to ask you one of the toughest questions of the day, and I'm sorry. So when I look at Prima versus Paula, 2 very impactful frontline trials, and I see, as Leslie very nicely said, that there was an impact in the HRP, in other words, the non-HRD group. But I didn't see that in Paula. So I want to explore that. I know we're not going to get to the answer, but these are the questions that everyone's asking. So is the reason that there was no benefit in Paula-1 in the HRP subset? I'm going to give you some choices. Maybe there's another answer. Is it because that niraparib really works in HRP and olaparib doesn't? Or is it because the bevacizumab negated the effect of olaparib? Maybe olaparib works great and not great, but as well as niraparib in HRP, and bevacizumab sort of negatively affected that, or something else.
Yeah, I think without a head-to-head comparison, we won't know, and this is the tricky part here. I think dose might matter in the proficient population, and I think we probably are getting a little better dose or penetration to the tumor with niraparib. So perhaps that slight difference, maybe they're the same as far as PARP, but we can get a little better dose in the patients that are wild type or HR proficient. I think probably both things are in effect. The Bev is helping the placebo arm, and to do better in negating the effects of what we see with olaparib and Paula. So I don't know the answer. I think that, it's nice that we have an option for PARP in our proficient patients. Mm-hmm. So I think I'll leave it at that and say, thank you, FDA, for giving us some choices.
So Shannon, I want everyone's opinion on this, because this is what our audience wants to know. This is what I want to know.
Yeah.
One of the things, and this is not meant to be a commercial. I'm not trying to sell anybody anything. I'm trying to help patients. But if I get it that I'm a co-author in many of these papers, and I don't want that to influence my opinion. That's why I'm gonna let you talk. But niraparib is the only PARP inhibitor in treatment, and we're gonna talk about it, approved beyond BRCA. It's just the facts.
That's right.
And niraparib, you sort of in NOVA, again, in treatment maintenance, the effect was pretty well defined. When in study 19, it was a phase 2 study. Is niraparib sort of higher tissue concentration more effective at cytotoxicity? I'm not going to get into the mechanism of action, or do you just think that these are sort of clinical trial design issues?
Well, yeah, I mean, I think I've seen the data around the penetration, and it does give you a sense, but I don't know that we've ever been able to really prove that has any impact on efficacy. And these are different populations, right? So,
Yep.
The Paula group, the Paula patient population is very different than the population from Prima, which was more of a bad actors. So perhaps you're seeing a difference, but maybe, and it's statistically significant, but really how clinically significant is it, based on the patient population. The other thing is got to remember that there's an active comparator, right? These patients aren't in Paula, they're not getting placebo, they're getting bevacizumab, which we know is an active drug. And so that potentially could be impacting it. And we've all had a sense that it seems like the Bev control arm acted or performed a little bit better than what we would expect, maybe a little bit. And so perhaps that had something to do with it. But with that being said, I'm intrigued by the early overall survival results that were presented at the time with Prima, looking towards a hint in that homologous recombination proficient group. So I'm eagerly awaiting those results to see if that plays out, because then that would indicate potentially that you are getting some more tissue penetration and you are benefiting a patient with your sequencing and giving that PARP earlier in their disease.
So we get better at these targeted agents. What you said is, Bev did a little better. Why would it do better in PALA-1? If you look at the discontinuation rate in 218, it was about 20%. We're just learning how to handle the proteinuria and the hypertension, that sort of thing. In PALA-1, the discontinuation of bevacizumab was about 5%.
Right.
So these agents work only when you use them. And if you can keep patients on treatment longer because you understand the supportive care, there might be a bigger benefit.
And
so,
if you design your trial based on what you expect,
yes,
and
right.
then it performs, and you're right, we are better at it. We're much better at it. And so I do think that's it, but they designed it based on the prior data, and that impacted the kind of appearance of statistical significance and clinical significance.